Welcome to today's webinar. The topic for today is Sunbeam, game-changing exercise for fall prevention for residents of long-term care. My name is Kelly Sullivan and I'll be hosting today's presentation. As a reminder, this webinar is intended to provide general information, not legal advice. We have a great expert joining us today and I'm honored to introduce her. Dr. Jenny Hewitt is a practicing physiotherapist, educator, and academic researcher with a passion for delivering best practice and leading research that informs healthcare policy. She was awarded the Aged and Community Services Australia National Lifetime Achievement Award and a National Commendation for Better Practice from the Aged Care Quality Agency for her work on the Sunbeam Program in long-term care. In 2019, she won the Morley Award for the paper most likely to influence policy and practice from the Journal of the American Medical Directors Association. Her work has been used successfully to advocate for Australian aged care funding reform. She was invited to give evidence on a role of physiotherapists in aged care at the Royal Commission. Dr. Hewitt also has worked as a technical advisor to the Federal Chief Allied Health Officer in 2021 through 2022 for an implementation plan to translate and scale her exercise program to practice in Australian long-term care facilities nationally. Jenny, I'll turn it over to you now.
Thank you so much. Thank you for having me. I'm delighted to be here. Just to give you the heads up, it's 6 a.m. Wednesday morning in Australia and the middle of winter, so we're topsy-turvy. I'm really excited to talk to you today about the Sunbeam program. It is an exercise program designed because I really felt when working with older people in long-term care facilities in Australia that there was so much more we should be offering, giving them a chance to work towards goals and have some dreams and have some excitement rather than just offering maintenance programs or supporting them in nursing ways. We could actually give them some rehabilitation options as well. I include this photograph you can see now on purpose. It's not a slide photo, it's not a file photo. It's an actual photo of some of the residents that participated in the Sunbeam program. And when asked when all was finished for the trial, how they'd like to celebrate, they opted for a Harley Davidson ride. So it just reminds you, what kind of old do you want to be and what kind of old do I want to be? And that is enabled to do things that still bring me joy. So with that as the backdrop, today we're going to talk about exercise restoration, reablement after injury or illness, cost effectiveness, and evidence for changing care models. The learning objectives of today are so that you can identify risk factors associated with falls in older adults. So I'm a physiotherapist, which I believe you may call physical therapist, but therefore I sort of focus on strength and balance. But there are so many other risk factors that are important to consider, so we'll touch on those as well. Then we'll describe best practice exercise for the prevention of falls. Exercise is like medicine. You can't just give any old type of exercise and expect to get a therapeutic benefit. In the same way, you can't give any old medication and expect it to work for all sorts of conditions. So we'll describe exactly what is required to prevent falls in older adults. And then I'll hopefully impart some research that you'd be able to talk about later. So just as a bit of background, I was disillusioned with the way that physiotherapy was funded in Australian residential care because it was predominantly focusing on passive, outdated modes. So I wanted to search for evidence. Then when there was evidence was lacking, I either needed to change my job or try and contribute to the evidence. So we conducted a cluster randomised control trial and a cost effectiveness analysis, and then to use the results to advocate or lobby for change. So back in 2008, when I first started thinking about all of this, there was a funding model that's outdated, hence the black and white photos I'm sharing with you now. Basically, it was massage or TENS machines, which are small electrical devices that were used, that these were the only kinds of physiotherapy that were funded for use in Australian long-term care. There was no funding at all for any interventions that targeted physical function, falls prevention, improving people's mobility or their confidence. And that just didn't sit right with me, because working as a clinician with older people, I knew that they had a lot more that we could do there was a lot more we could do to help them than purely passive pain relief. So I went and searched for the evidence. I had a look in particular at falls as the outcome because I knew if I wanted to advocate for change to funding rules in Australia, there'd have to be evidence of benefit. And policymakers listen to falls data because falls cost the health economy a lot of money. It's not just the human side of it, but also the financial side. So I chose falls as the primary outcome for my research, but I must say that it's people's quality of life and changing their lives that is my primary driver. That being said, if you look at falls, these are the known risk factors now. Falls can be predicted. They're not just a random event. If we were to take a person who's had a fall and sit down with them and review their medications, their nutrition, if they've got pain in their feet because it causes them to changes their gait pattern, in fact, pain anywhere, because then they're multitasking, particularly if there's a cognitive impairment. If they've got pain somewhere else, it increases their falls risk because they're not focusing so much on risk, how they're walking. Incontinence, clearly, because if you're rushing. Vitamin D deficiency is also associated with an increased falls risk, as is visual impairment, a number of comorbid conditions, cardiac arrhythmias, and environmental hazards. So if we're doing a thorough falls assessment, these are the risk factors you should look for. But we're talking today about strength and balance because regardless of all of the other risk factors, if you start to fall, you need to be able to react quickly and then you need to have the strength to catch yourself. So back in 2010 and 2012, when I was setting up this trial, I had a look to see what is the evidence for the prevention of falls in residential care. Residential care is what we call long-term care in Australia. There was only evidence for taking a pill, which everybody loves, of course, because it's easy. Vitamin D supplementation did seem to reduce falls. But if we're looking at exercise interventions, it was saying back then that the results relating to the effectiveness of exercise in reducing the rates of falls was inconsistent. In fact, the clinical practice guidelines from both the American and the British Geriatric Societies back in 2011 said that there was no randomised controlled trials to provide evidence to recommend for or against the use of customised exercise programs. So that pretty much spelled out what I needed to do. And that had a ripple effect. You know, when you write, we don't know if exercise works in this setting, the ripple effect in those high quality research papers, the ripple effect is that people stop funding them. And so that's what I was seeing back at that stage. And that really needed to change because that wasn't in line with what I was seeing as a practicing clinician. So I took a look. Don't get too freaked out. I'm not going to go down the research rabbit hole too much, but we do need to have a look at what was being used to make those decisions back at that time. So this is back in 2010 and 2012 in the Cochrane Collaboration Review. You can see there's only a few studies. There's not very many. That's the first thing to notice, set in the long-term care setting. And then those red squares you can see are scattered either side of that vertical line. And anything to the left favoured the intervention. That means the exercise program did help. Anything to the right means that the participants in that trial would have been better to stay in bed than to do that particular type of exercise. And you can see then if you're doing some mathematics and putting together all of the results on where the red dots are, they even out and end up with that black diamond at the bottom, which says we don't know whether exercise helps or not. It's sitting right on the line. So the question for me at that point, my light bulb moment, if we think of exercise like medicine, as we should, then the type of exercise, the dose of exercise and the frequency of exercise all matter. In the same way that if a diabetic was to come into a medical clinic and be given paracetamol to try and even out their blood sugar levels, it's the wrong type, so it's not going to work. If they were given insulin but at a half dose, it's the right type, but it's not going to reach a therapeutic dosage. If it's the insulin at the correct dose, but they're asked to take it once a week, it's still not going to be effective. And we really should be thinking of exercise like that. One type of exercise is not the same as the next, in the same way as one type of medication is not the same as the next. So I thought, what if all of those studies were doing the wrong type and dose of exercise to prevent falls? So what was the right type and dose of exercise? Luckily for me at that time, I'll just bring that slide forward. Luckily for me at that time, there was a study published by Kathy Sherrington and Ann Tiedemann, a physiotherapist and exercise physiologist, that had a long list of best practice exercise for falls prevention. So I was able to map that against what I was seeing in those studies. Now, the studies that I showed you a moment ago on that forest plot, there was 3 of them that did improve falls rates. One was perturbed walking on a split treadmill. So they were getting their people to walk on a treadmill that was tipping them a little bit. Another one was computer balance training. I don't think that's what they meant by computer balance training, but I couldn't resist that photo. And another one was a Pilates style resistance and balance training. The exercise programs that showed an increase in falls rates, however, all had walking in them. And so up until that point, I had thought that maybe any type of exercise, even I had thought maybe any type of exercise is better than no type of exercise. But you may recall on that forest plot I showed you a minute ago, there was one exercise program that really increased the falls rate, and that was getting people up and walking before they were ready. What that told us is that asking people to start walking without first improving their balance, their strength, or their writing reactions can lead to disaster. So let's not call walking programs falls prevention programs, even though they are good for other things, other health conditions. The components of effective falls prevention are as follows. It needs 50 hours minimum over 6 months. So this is in older adults. That's 2 hours a week. That's a lot even for, you and I. High challenge balance work, which I just was not seeing in the long-term care setting. Strength work for people who are deconditioned. And let's face it, most people in long-term care spend the majority of their time in a sedentary position, sitting or resting. And so strength work is paramount. All exercises need to be individually prescribed and upgraded and progressed, closely supervised so that they can have the high balance work. A maintenance program after we've got their initial conditioning up, same as you and I. If you go hard at it for 3 months and then stop, you turn back the other way. And a walking program, while beneficial for other conditions, is certainly not a falls prevention program. So I went back and mapped that to that forest plot I just showed you, and not one of them had implemented that kind of type, dose or frequency of exercise. So it pretty much spelled out what we needed to do. What we decided to do was to conduct a cluster randomised controlled trial. A cluster randomised controlled trial means that we recruited 16 aged care homes, and we recruited them in pairs, and one care would be one care home would be randomised to receive the gym and the exercise program, and the other would be matched as its control or a usual care group. The key research questions were, is a supervised progressive resistance and balance group-based exercise program more effective than usual care for the prevention of falls over a 12-month period? Does it also improve quality of life, cognition, mobility and confidence? And is it cost effective? Australia is a big country. I live over near where those little sunbeams are. So we conducted the study in 8 pairs, so 16 aged care facilities, predominantly in that area that you can see on the eastern border, which is where I'm sitting right now too. It was a multi-centre cluster randomised controlled trial. The assessors were blinded as to, or masked, I think we call them these days, and there was 221 older people who put their hands up to join in. It was called Sunbeam because I put the word strength and balance exercise in aged care into the acronym finder, and it popped up with SNBEAM, SUNBEAM. It also popped up with stable, STABLE, which I thought was rather nice, but the residents told me it made them feel like horses, so we bailed on the stable. This has got a lot of information. This is taken straight out of the JAMDA article, but the reason I show it to you here is I want you to just get a feel for the type of people who said yes. It was ambulant people because we were looking for falls prevention, and most people who are non-ambulant have a lower falls risk. The mean age was 86 in both groups. The oldest was 101. There were more females than males, which stands to reason because of the life expectancy situation. Sorry, boys. And also from the fact that more women were in the aged care facilities that participated in the program. There were more people who had fallen in the 12 months prior to the study were in the intervention group compared to the usual care groups. Most of them used mobility aids. There was also more high care, meaning they had higher nursing needs in the intervention group, which is just how it worked out with the randomisation. And as you can see, they had all these comorbid conditions as long as your arm. You don't generally have fighting fit, healthy people living in long-term care. So anxiety and depression, cardiac, cerebral, cognitive impairment, and so on that you can see here. And what did we do for the exercise program? It was progressive resistance training and high challenge balance, 2 hours per week over 50 hours. So basically implementing exactly what that research had said was required for falls prevention. The progressive resistance training, I didn't want to get it wrong. We could have used simple weights or resistance bands, but because there was all this research out there already saying that we don't know if exercise worked, I wanted to know that each person was getting an individually prescribed therapeutic dose of exercise. So where they'd be working, doing 2 to 3 sets of 8 to 12 repetitions at a load for every exercise that was individually prescribed for them to be a moderate to somewhat hard resistance. So by the time they've done their, say, 12 repetitions, it should be somewhat difficult. And in order to be able to do that confidently, I decided to work with her health and fitness equipment, and we used the hip abduction and adduction, so taking the hips in and out against resistance, leg press, which uses a whole range of muscles, so from your hip at the back of your hips, your glutes through to your quads, a bit in your calves. And we used the tricep dips, which is pushing down so that their arms get a bit stronger and they can push themselves up out of a chair. What else do we use? Knee extension, leg curl, so pushing their legs out to get the muscles on the front of the thigh or the quadriceps, curling underneath to get the hamstrings on the back, and then a piece of equipment that exercises the abdomen and the back. So every person had an individually prescribed program using those key pieces of equipment to exercise those key large muscle groups that were helpful. You can see it's mainly lower limb exercises, but a little bit, one for upper limb and some for the core. Individually prescribed at that set dose. And then while they were on the gym equipment performing those resistance training exercises, I could get one person off at a time and do the high challenge balance exercises like you can see me doing there. That's the grapevine, or a little bit of a tango, etc. Thanks. You might need to let you go a bit higher. You want to park it at the end there? Have you finished all the machines now, Bill? Okay, so we'll put it in, make sure it comes up with hello Zeta. All right, that's good. 2. So keep an ear out. When the machine beeps, you've done your 10 and you can have a rest. That's good. Step behind, step in front, step behind, step together. Well done. That's good. So this is helping you balance at the same time because you're not hanging on to anything. That's right.
Flat on our feet and heels. Keep those legs nice and straight, but hang on when we're going backwards. Up on our toes, flat, and back on our heels. Lunchtime, sun's over the yard arm. We're going to reach for our champers. And just get that nice, we're on a boat, we've got a bit of a swell, rocking, rocking, reaching, reaching. Drop out, push our leg this way, so everybody, we're falling, falling, catch. Falling, falling, catch. Falling, falling, catch. Are we ready? Falling, falling, catch. Falling, falling, catch.
As I said, we had 8 care homes who participated in the gym program for a 6-month period of 25 weeks actually, and then we followed them up over a 12-month period. The paper was published in the Journal of the American Medical Directors Association. There's the reference here. And the take-home message is there was a 55% reduction in falls rate. So getting their legs stronger and improving their ability to catch themselves should they fall, or to be able to reach for things without tipping over, to be able to balance even if, with their eyes closed, even if the lighting is low. These things altogether resulted in a 55% reduction in falls rate, which was a game-changing result. This is a snippet out of the JAMDA article. It shows the falls rate per person per year. The total number of falls, you can see there, 142 versus 277. The number of people who fell, the number of people who had multiple falls, and the injurious falls there. So that was looking, injury meant documented pain, bruising, lacerations, or fracture. All of those were significantly different. By the time we get down to the fall-related fractures, there was a big toe or two in the intervention group there, but that's not enough numbers to perform any statistics on. I wanted to show you this one, which is just a one-off, and it's a bit of a poor quality photo, but you can see that here this person this is to lift the leg up, so strengthening the quadriceps muscle in the front of the thigh. He had made a 257% improvement since his first day, so we were able to track progress, and that was so motivating for our older adults as well. And we had this lovely feedback here. We weren't really targeting pain, and I was a bit worried about pain, if we stirred up any underlying conditions, because it's hard for these people to recover. But we had the opposite, my pain is less, is what we were hearing. My mum used to be in and out of hospital a lot of the time, and now she hasn't been in for the whole time she's been on this program. This lady here, you can see in the photo, was 101, and she never missed it. She did not miss a single session. She used to be a nurse, and she really wanted to contribute to the health policy debate and say, even if I'm old, I should be given the chance to get back on my feet if I want to. She used to say her get up and go got up and went, but then she said, as you can see here, they've been beneficial. I have much more get up and go now.
A world of difference. I can walk taller. I'm just so much more able to get about. It's wonderful. As I said, I was a couch potato and I didn't move, and just one day was like the other. Now I look forward to the exercises very much.
And I got out of the car and went to step up the step and tripped on something and went forward violently so that I was parallel with the ground. And I kept on moving and forced myself upwards, and I eventually prevented the fall. I was able to straighten myself up. Yes, I would have fallen flat on my face if I hadn't had those exercises.
Leg-wise, strengthening your legs, to be able to push up from the floor without your hands, and get down into your chair and up easily, and just to generally overall they strengthen the body.
I can just move with my family a little bit more. They don't quite have to wait on me quite so much.
Actually fell where I aimed for, really, on the floor, and dodged everything, and it was a good result, and that came from these classes.
There's only one way to go now, and that's up.
It's very tempting as a falls prevention researcher, of course, to leave out the bit about falling where you aimed for. But the good news of that one is he didn't lose any confidence. He wasn't injured. He got himself straight back up and carried on. And having confidence in yourself is also an important factor when rehabilitating people who have falls. So in summary, the trial demonstrated evidence-based exercise in residential or long-term care works for falls prevention. They also had a statistically significant improvement in their physical performance measures. So that was balance, walking, and ability to get out of a chair. We performed a subgroup analysis about 2 years ago using the same cohort, but looking particularly at people with a diagnosed cognitive impairment, because there's a real lack of research and evidence for that group. We were able to demonstrate that they also had a 50% reduction in falls rate when participating in this exercise program. And it is cost effective. I'll talk through that a little bit more in a moment. These are Australian dollars. But these things were brought up in the Australian Aged Care Royal Commission. And so it was really good to have some evidence behind the reason that we should be helping people, no matter how old they are, if they want to be able to get back on their feet. There are methods we can use to get there. The study's been used since then In 2021 and 2022, the Australian government decided to implement the Allied Health Group Therapy Program. They asked me to put together a protocol that could be used with or without a gymnasium. With a gym, we were able to have 10 people at a time in the group. And so it's actually a lot more cost effective than without, because without we were only able to have 4 people together to run the same programs. There is a video here implementing the Sunbeam protocol. If you would like, then that shows you how to prescribe and upgrade the exercises according to the protocol. It's freely available, and if you put in the keywords group therapy Sunbeam video into Google, you'll find it. You don't need to be able to read these slides. It's just to show you that targeted exercise is now recognised as the best pain relieving program as well over passive treatments. So often we think, oh, we better not ask people to exercise a stiff arthritic joint or a frail person to exercise. But unless we ask them to exercise, we're just not delivering best practice. There's strong level 1 exercise for falls and for turning around the effects of long-term sedentary behaviour all round. It's best practice exercise for pain management as well. In fact, the key message, and this is from a level 1 research performed in Scotland, they pulled together all the best practice pain relieving research trials and came up with these key indicators. In terms of physical therapy or physiotherapy, exercise, you can see there's nothing there about massage for these things, even though it feels nice. It doesn't give you any longer term benefit. Supervised exercise sessions, individually prescribed in group settings. Supplementary material means educating people about appropriate postures and stretches and so on. And doing a combination of group and home exercise were the key recommendations for chronic or persistent pain across the lifespan. This is a video, but I'm going to just say it because I was just so, he warmed my heart. This fellow was one of the participants in the trial, 94 years of age, and he wrote a little poem after the exercise program that went like this. A man's not old when his hair turns grey. A man's not old when his teeth decay. But a man's fast reaching his long last sleep when his mind makes an appointment that his body can't keep. And I think he summed it up. If people want to be able to do things, then we have the knowledge on how to prescribe and deliver best practice exercise, then surely we should be doing that for people. Obviously, it's not just balancing people, we need to balance the books too. So we wanted to look at the potential financial benefits for seniors, the aged care providers and the health economy more generally. So I won't go into this in a whole lot of detail. That paper is available online if you want to look at calculating incremental cost effectiveness ratios. Basically what happens here is you look at the cost of the intervention and you subtract the cost of usual care. And then you look at the effect of the intervention minus the effect of the usual care. So the more effective the intervention is, the more it brings down the total cost. And it costs $22 to avoid a fall. So when you look at how much falls cost the health economy and how much human cost there is, not just for the people who fall, but also for those of us who love them, $22 is a tiny amount to prevent a fall. We conducted this cost effectiveness analysis, and the reason that it came down to $463 per person Australian to implement the 6-month program is because the smart card system, or which allowed us to not have to take notes. So you saw on that video that we put a little card in and it popped up with that lady's name. It automatically adjusted the equipment to the individualised number of kilograms, the number of repetitions and how many sets she needed to do. It takes the notes for us. It allows us to see if somebody achieved the dosage too easily, and so therefore we can progress them. So having that technology, even though it's expensive, it meant that we were able to then have 10 people in a group, and the equipment has a 10-year warranty. So compared to buying smaller weights and so on, where you have to manually take the notes, you can't increase by the tiny increments you can with this equipment, and you can have to have smaller group sizes. It actually turned out to be approximately 4 times dearer over the 10-year period to use the simpler equipment than it was to make the initial investment. We had groups of 10, one physio visit per fortnight. Because everything's saved on the smart card system, we could get therapy assistants or physiotherapy aides to run those group sessions for us, and the physio only had to go in once a fortnight. To calculate the cost of treating a fall in Australia, if somebody has a fall in long-term care, the RN, registered nurse, I beg your pardon, the registered nurse does the initial assessment. Then the physiotherapist usually does some kind of follow-up. The medical practitioner usually has to have some kind of follow-up as well. Then there is usually 2 to 3 days of follow-up assessments afterwards to make sure the person's improving appropriately. And then there's the issues that if somebody used to only need one person supervising them and walking with a, for example, four-wheelie walker, but now they've had a fall and an injury and we need 2 people using a mechanical hoist, there's all of those long-term costs as well that are factored in. And thankfully, I'm a clinician, I love working with people, but thankfully other people love working with numbers. So I partnered with health economists who were able to then sort of perform some scenario analysis. So if a long-term care home with 70 residents implemented the program, there'd only be about 25% of the residents who put their hand up and say, yep, I want to do this program. So that's the conservative estimate. If we do nothing new and just let them people continue with the seated gentle exercise programs that run as standard practice in long-term care, there's likely to be around 64 falls per year, and the modelled cost is about 110 or 111 thousand Australian dollars. If they fund the Sunbeam program, those same people there's only likely to be 28 falls per year, and you can see there's a massive reduction in treating the falls, applying the same modelling principles. So it's about $62,000 in the first year, and then you multiply it by 10. In terms of best evidence now, I'm thrilled to say that now it doesn't say we don't know if exercise works. Now it says that this type of exercise, targeted progressive resistance group exercise, individually prescribed and high challenge balance does work. Those gold bars you see there are showing how many good quality trials are there. This is in a level 1 systematic review. There's a new one of these coming out at the end of this year, and there has been a couple of other exercise studies also contributing to the research. So now it's recognised that some types of exercise do work in long-term care, but just not all types of exercise. So I just want to acknowledge the staff of all of those villages and the residents and the rest of the team. There is in this slide physiotherapist, a health economist, an occupational therapist, an exercise physiologist, and her health and fitness equipment who provided the equipment for the study. I'd like to just give a real life example because it's one thing to talk in statistics and numbers and scientific evidence and so on, but to see how these things have actually helped lives is really important. So I like to talk about this fellow who I met when he was 80. He had cerebral palsy. He'd been born with that, and it was kind of unusual to meet an 80-year-old in those days, even now, because they didn't seem to survive as well as they do now. And so he had that classic cerebral palsy presentation where his right arm was contracted, the elbow was contracted, the wrist was contracted, the fingers were too. The right leg was sort of turned in or internally rotated and bent, and he walked with a significant limp. He also had a low four-wheeled walker where he used to bend in half and rest his elbows on the handles and walk with that limp that you see with people with cerebral palsy, and also bent over the wheeled walker. And when I met him, he's just so full of life and ambition. He used to like to travel when he was with his parents. He was an old man now. He was living in the long-term care, and he still had a dream of travelling. And he had a lot of ambition, a lot of enthusiasm. So when I started prescribing him with the exercise program, he was the one who would show up every week early. So the class would start at 9, he'd be there at 10 to 9, I'd arrive at 5 to 9, and he'd be tapping his watch and saying, "You're late." So he rarely, if ever, missed a session, 2 sessions a week but basically over an initial conditioning period and then long-term maintenance. It also was a really important social outlet for him. We used to group a whole bunch of men together who then became mates and used to enjoy catching up outside the gym as well. So I knew him, as I said, I met him initially when he was 80. By the time the Sunbeam Trial started, he was 85. So he ended up, thankfully, being in one of the sites that was randomised to receive the gym, not the usual care group. So he diligently continued there. At his 90th birthday just recently, his family called me and said, we're going to take our uncle on a cruise and we'd like to get a wheelchair for him. And I chuckled to myself and said, oh, well, I'm sure I could organise that for you. But they hadn't seen him for some time. And when they arrived to pick him up, they couldn't believe it because he was standing tall, walking tall. They did still take the wheelchair. And I said to him afterwards, how did you go on the cruise? Did you use the wheelchair? And he said, oh, yeah, I pushed a couple of the relatives around in it. So these are the stories that really warm my heart, and there's just so many of them. We've had a number of people who were told they would never walk again who are walking because they have had the opportunity to participate in this type of program. So in summary then, falls prevention, restoration and reablement are possible in long-term care if the correct type, dose of exercise are implemented. There is evidence of both health benefits and cost effectiveness of such programs. The key principles of the program can be used to scale. So the principles are 2 to 3 sets of 8 to 12 repetitions where the person feels the load is somewhat difficult at the end. So we're not talking super gentle, we're not flogging them either. And really measuring outcomes that matter to the end users, and the end users in this case are the residents themselves, of course, their families, and the staff of long-term care, because people work in long-term care because they like working with older people generally. It's not a glamorous job. We're here because we want to be here. So if we want to perform research, it needs to be outcomes that matter to those people as well as to the policy makers if we want to assist in changing policy and practice. Thank you for listening. I'll just hand back for the moment to see if there are any questions that you'd like to put forward.
A huge thank you to you, Dr. Hewitt, for your expertise. First question, did you utilize standardized balance assessment tools to help benchmark a baseline and quantifiable measure progression?
Yes, we used the short physical performance battery and the Hill step test. So the short physical performance battery is a 3-part test, and so it measures balance in you start with the feet apart and not hanging on, and it's timed, then the feet together and not hanging on, and it's timed, then a semi-tandem position, then a full tandem. Then the gait was a measured gait speed test over 3 meters, and the chair stand is a repeated 5 times standing up and sitting down out of the chair without using your hands. So we were also measuring dynamic balance, and that was performed using a 15 centimetre step where the person stands not holding on and they attempt to tap 1 foot up and down as many times as they can over a 15-second period. So both of those tests have normative data. They're used widely and internationally as well as in Australian studies. And they also had the side bonus of being quicker to administer than some of the longer balance tests. Because we were measuring cognition, quality of life, fear avoidance, as well as balance, gait speed, step test, the whole assessment, the initial assessment, and prescribing the exercises where the people were randomised into the exercise group. The whole assessment took around about 60 minutes. So that was those 2 tests were the ones we selected for physical performance.
Great, thank you. We have another one here. Could you please repeat the number of sets and reps of the exercises?
Yes, so every exercise was 2 or 3 sets. In the JAMDA article, we said 10 to 15 repetitions, which is what we did for the trial. Strength research has progressed since then. So nowadays I go 8 to 12 repetitions. But the actual JAMDA article and what we did back, because it started 10 years ago, it was 10 to 15 repetitions. So what that means is if, for example, it's quadriceps and we've got a person sitting down and we want to apply a load around the ankle and ask them to straighten their leg, it means that by the time they've done that 8 or 10 times, it should be feeling, we used the Borg scale of perceived exertion, it should be feeling somewhat hard. And you can observe it too, they're a little bit shaky at the end. And then we ask them, whatever that load was, we record that, and they'd have a rest period somewhere between 20 and 40 seconds, and then we ask them to repeat it, and then they have another rest period. Once they can do that 3 times, so 3 sets of 12 repetitions on that particular load, it's too easy. We don't increase the numbers, we increase the load. So 2 to 3 sets, nowadays I say 8 to 12 repetitions, and then once they can get to the point that they're doing 3 sets of the 12 reps, the load's too light for them and you need to increase the load itself.
Great. All right, here we have a question. I think your online video recommended 10 to 15 reps. Can you comment on the difference?
Yeah, so the 10 to 15 reps is what we did for the Sunbeam trial. So that was that protocol was written in 2012, and that was best practice recommendation at the time in that research at the time. Today, with today's knowledge, I do 8 to 12 repetitions. It still worked. The Sunbeam trial worked, and we did 10 to 15 repetitions. So what that meant was that it was slightly lighter. So 2 to 3 sets still. If you're doing, it's the same principles, 10 to 15 repetitions. So if we put, say, 5 kilos around their ankle and they can do 3 sets of 15, then we go to 5.5 kilos or 6 kilos or 6.5 kilos. We'd increase the load once you get to the top of it. So now when I talk, the Sunbeam trial used 10 to 15 repetitions, but now when I speak, I am talking with more contemporary knowledge about strength training, which wasn't available 10 years ago when we wrote that initial protocol.
What was the average resistance level weight used with the strength exercises for the participants?
Well, it depends on which exercise we're talking about. So, for example, for leg extension, what I used to do is make a generic card up with what was the beginner or entry level usual resistance for each exercise. So for leg press, so that is the one where you have your foot against the paddles and they're pressing out with each alternate leg. That one would usually be sitting at around about 10 to 12 kilos to start with, but then on day one, and then I'd be sitting with the person, or the other physios would be sitting with the person, and once they've done their, say, let's just pick 10 repetitions because that's not contentious, it's it's the same in the Sunbeam and the more recent study. Once they've done 10 of those, we'd have an actual printout of the Borg scale of perceived exertion alongside, which has, which I showed you on the slides earlier. It has a scale from 1 to 20. It has a green zone, which is between about 12 and 16, and they and some terms, somewhat hard, very hard, etc. We'd ask the person to say, where does that? How do you feel after that? And if they're pointing in the somewhat hard with that weight, then that's what the weight would leave. If they're saying, oh, it's a bit easy, then I'd be putting it up to say 13 or 14 kilograms. And we did that for every single exercise. So for seated knee extension, they might be on something around the order of, say, 1.5 to 2 kilos to start with, and they get tired. This is general, being general, because everybody was individualized. For triceps, it was probably about 7 kilos. So once again, it's just your starting weight. So it does take skill, and this is why it's prescribed by exercise professionals like physiotherapists or exercise physiologists. It takes knowledge to figure out what to give as a starting weight and where to go from there. But success is motivating. I would usually make it a little easier on the first visit so that the person feels that this is achievable, rather than starting them on day one with a really heavy weight, which make them feel like it was quite hard work and education on delayed onset muscle soreness is really important. So I would say to my people, and I trained all the physios to do the same, if you wake up tomorrow morning and you feel a little sore in these muscle groups, it's just like it was when you were young and you played a game of squash for the first time, or you went for a big bushwalk and you wake up the next day and your muscles are a little stiff and sore. That's actually a good thing. We celebrate it. It means that we've picked the right dose for you. If you wake up though tomorrow morning and you're sore in your joints, then let me know next time you come in and we're going to adjust the weights for you. It was that piece of education that turned out to be really important, because a lot of older people in particular, if they wake up with any symptoms the next day, they're afraid that it's done them harm, and so they don't necessarily want to come back. So that was an important part of it too.
We will be moving to the product portion of the webinar now. We hope that you can stick around to learn more about the HER Smart Balance assessment tool that assesses balance, accurately identifies users with high risk for falls, and implements results-based fall prevention and balance training programs. So to learn a little bit more, stay tuned.
Thanks for sticking around. I have Carol here from Her Fitness. We are been partnered for quite a few years now. We are both here to introduce a product to you from the Her Fitness product line called the Smart Balance, which focuses mainly on assessment and training for balance and stability. But Her Fitness carries quite a few other products too. So Carol, I'll let you explain kind of the portfolio and a little bit more about Her Fitness.
Great, thanks Kelly. Yeah, Her Fitness has been around for about 35 years, and we're well known for our pneumatic strength training equipment, so air pressure, strength resistance. That equipment is wonderful for a wide range of abilities, so you often see our equipment in therapy, senior living, but all the way through to independent and active people. It's a great workout. We also offer Smart Balance, which is a testing and training device. It can integrate into our Smart Touch system as well.
Yeah, it does, and it can be curated to an individual, right?
That's
so
right.
Each and every assessment and or trainer can be kind of created for that individual.
Right, they could just use their RFID key fob to either log into this equipment, the strength equipment, or come over and do some balance training.
Absolutely. So first we're going to talk about the external features of the Her Smart Balance before we dive into the computer-based software options. So I'd like to direct your attention to the force plate on the bottom here. One thing to call out is that it has a very low step-up height of only 2 inches. When you look comparatively at our competition out there, maybe other products that you've researched on your own independently, you might find a step-up of 13 inches, which could be a little difficult for someone in their 70s, 80s, or 90s even to clamber onto it.
It's hard on the hip, right?
It sure is,
Getting
yeah.
up. Yeah.
Or if they just had a surgery,
Right.
very difficult. So nice low step up, wide force plate, easy to get on and off. I want to call out to the stability frame here, which is integrated into the platform here. So it's very stable. It's a nice place to put your hand if you need to restabilize yourself during some of the activities. The computer interface is going to be height adjustable, so we can accommodate a lot of different types of folks. But the most important thing I want to call out is that it's easy. The easeability of a product is the name of the game in long-term care. And so this product, you quite literally can get on it, jump into a game or an activity, or even do an assessment without having to do any setup, which is wonderful, right?
Yeah. Yeah. We're all busy, but we need these things. These are important. We would just want it to be kind of on demand, right?
Absolutely. Yeah.
Yeah, so we were thinking that the next step here is to show you a little bit about what it can do. And really we've got 2 areas. We've got the testing side and then the games and training side. The testing side, as you know, Kelly, is clinical. It's standardized tests that have been used throughout the industry, Romberg's and limits of stability. And then there's also a weight, so you can do BMI, adding in your height. But those 2 tests on this system, the results for the user are compared to normative data. So comparatively to someone the same age and gender, thousands and thousands of results, your score is compared. And so that really gives you, good feedback that's useful, and it's not just a random score, like high score, congratulations.
Yeah, exactly. Well, should we try one out?
Let's do it.
Okay.
Let's do it. So we're going to start with the trainers. All right, so stable, unstable Romberg's. So Kelly is on what we would call stable. If we wanted to go unstable, we'd be adding a blue foam cushion. There's 4 tests in this with stable, unstable, and I'm going to log in just to keep that information private. There's always a login code. She's going to do this first test stable. We're just going to do one because we don't want to take up too much time. All right, so the idea here is how still can Kelly stand? We're going to start with eyes open, and it's going to be a 5-second countdown. Here you go. So for 30 seconds, Kelly is going to stand still. And you probably know this. This is Romberg's test. But this force plate is very sensitive. So it's capturing any little sway. Now, Kelly is in heels, so it's a little more challenging for her. But I know she's going to do great. And the screen is dark on purpose. It's dark because we don't want that visual help, which so often we rely on for our stability. So she is just having to stand there with no feedback loop. All right, we immediately get this screen, which is, do you want to redo it or accept this? And of course, we all get interrupted sometimes or things happen. So you can always just redo the test. But Kelly passed, and I'm going to say accept. Now, you're going to skip the next 3. Normally, you would do all 4. All right, we're going to save that information, and we're going to go right to Kelly's report. And what's great about this is there's both a very deep level of data that the clinical team can use and analyze, but there's also just a very easy stop and go light. So green means you're good, keep up the good work. Red is you're at a high risk of fall compared to others in your same group. So good job, Kelly. You did a great job on this. There's also a little touch screen printer button. So if you want to print those results, if you need to share that with permission from the resident, you can. All right, so let's hit the X there, Kelly. We're going to just back out of this. So you have your tests. I'm not going to do limits of stability or the weight.
Thank you.
Yeah.
I appreciate
For
that.
everybody. We're going to go right into the games and the trainers. So the trainer side, there are 7 different trainers, and there is something for everybody, just depending on your learning style. There's also what we call games. Now, all of them are helpful, right? They're really all trainers. But the difference is in the games, they're a bit more gamified, they're more graphical, they're really like playing a video game, but you're working on your balance. So we have one that's a little bit like Mario Kart, and it's called Tux Racer, or Tux Kart, and then we have Tux Racer, which is the penguin going down the hill. Let's do that one, okay?
Okay.
All right. So Tux Racer is a penguin going down a mountainside, and Kelly's goal, go ahead, yep, and then hit race, is going to be to try to capture those herrings. So let's see. Now, when Kelly leans forward and shifts her weight forward, she goes faster. When she stands up tall, even comes back on her heels a little, she'll slow down. But you can see she's shifting her weight. The force plate is feeling that and controlling the course of the penguin. So she's working on her proprioception. She's working on her awareness of where she is in space, and she's shifting her weight. Good job. Also cognitive at the same time.
Ooh,
All right, Tux hit a pine tree. It happens, and he gets right back up and goes after those herrings again. I see the finish line. Excellent.
Finishing strong.
Woo! All right. Good job. All right. So that's just an example of one of the fun games. And again, somebody could just step right up, play that game, do that on their own. You also have the ability to compare not only results of your assessments, but your games.
And I'm very competitive, so like it'd be fun to see like how I measure up against my last score, to kind of push me to that and to get better at the game.
I know communities that have this, that actually have like a leaderboard for best scores, and people do get really competitive. Now, we just played this today, like just a step on and go, step on and train, which is great. But there could be communities or places that also have our strength training equipment with Smart Touch.
Yep.
In that case, the little RFID key tag that goes with our equipment and is assigned, so Kelly's key tag, she could work out on the strength equipment and then come over and swipe, and her preloaded games would come up and then keep track under your name of how you're doing and how many times you've played.
So it's a very curated program then
Yes.
for that individual. That's
Yes.
really cool. Well, we appreciate you sticking around and spending time with us and learning more about the Her Smart Balance. If you do have additional questions, please don't hesitate to reach out to your account manager. Carol and I are your support team. We're here to provide any information you're looking for if you have further questions about the system and or any products from Her Fitness in general. So we thank you. You have a wonderful day.